that makes us different. But as a whole, 99% of all humans, whatever our species is, I'm not that good. I'm not an anthropologist. I can't go into the species and I know we're all humans. We all are the same. But there are certain things about us that make us uniquely different, not only within our race, but among our family members and everything. So there's a lot that we share and very little that we don't. And so ethnicity differs from race because it's not looking at the physical traits. It's now looking at how we live our life, our cultural connection. So this talks to relating to a large group of people, common racial, national, tribal, religious, linguistic, cultural, and origin or background. So the foods we eat, the traditions we share, that's our ethnicity. So when you hear people talk about race and ethnicity, they group them together all the time, but they are different. Because you don't have to share the same physical traits as myself to share the same religious or cultural or lifestyle, right? So be specific in what you're asking for when you're asking for resources. That's why I say they'll always try and group it based off of a race. Oh, where you're black isn't actually a race. When you do think of races, there's 3 races: Mongoloid, Caucasoid, and of course, Negroid. But, we didn't make those up either. But those are the 3 races that people fit in, but we all have a different ethnicity. Okay. So why do we mistrust the system so much? Well, we have a lot of reasons why, but I would like to have you walk away today feeling like there has been some progress and that you can develop an alliance with your healthcare provider and hopefully develop a bond and trust. And if you can't trust your healthcare provider, look for another one. You have that right. I don't care what your HMO has assigned to you. If you are not comfortable with your healthcare provider, you can seek another provider. And they try to group you together, but you do not have to take that as the final word. So 2/3 of people, minorities, actually feel that the health system treats them unfairly. Does anyone in this room feel they are always fairly treated by the health system? Yeah, I'm keeping my hand down too. Exactly. So maybe we should make that 3 out of 3, but yeah, 2/3 of individuals feel this way. And because of that, over half of those individuals will skip appointments. But then when you skip the appointments, then they mark you as non-compliant, or no, you have to dig deep. Why didn't I come? But people don't do that and it's not always the fault of the physician. The physicians are overworked, understaffed. And then they're just coming in and they're like, you wait an hour just for them to touch you and then walk out the room. Like, wait, what just happened? They're not getting the full information that they need to serve you, so you have to demand that of them. And then minorities don't participate in clinical trials. So that was something else we discussed a couple of months ago with the Mayo Initiative, clinical trials. We're not participating in that. So we're not getting the data that we need, or we're not being able to appropriately show health systems that we are not being treated appropriately. Because if we participated in these clinical trials, they could show outcomes, because clinical trials, they're watching you, they're keeping up with you. They want you to do well, they want you to be healthy in these trials. So now they say, well, wait, this whole group of African Americans, every time they're in these clinical trials, they're excelling. Their health is doing well. They're healthier. I'm reading about their lifestyle. Everything seems to be going a little better. Why is that? But because we're not in those clinical trials, I just sent an article to a group, the ABC, Association of Black Cardiologists, where it looked at medications from 2008 to 2017 for cardiometabolic medications. That would be diabetes, hypertension. And they looked at all of these pharma companies that had done studies to get their medicines approved. If you look, and this is not just U.S., this is global. This was a global analysis. Less than 2% were African American. Or, I'm sorry, were black. They classified as black, because you can be black without being American. Less than 2%. Now, this is global. And then, on top of that, less than a third of them were female, where we have, 50-50, just about? And in some places, 60-40. But we are always misrepresented and underrepresented. We can go to the next slide. And this it just goes back, like I said, 19th century. I think I may have mentioned this before about the physician who advanced a lot of tools in the field of gynecology by experimenting on an enslaved black woman without her consent, or their consent. It was more than one, but one, I think he had operated on her like 12 times, or without anesthesia, because in his mind, black women didn't experience pain. And then between 1932 and 72, so I'm sure everyone, well, maybe not everyone, but mostly, almost everyone in this room was around, or at least born in this to this earth between that time, the Tuskegee Syphilis study, which went on for years, decades. And this was a government-funded study where they literally followed men, black men in the South, and they told them they were treating them for their syphilis, when in actuality they were not. And they were just wanting to see what would happen to the body with untreated syphilis. And so you think about, these men were lied to, first and foremost, and not only were they lied to, their families were lied to. And so if the men had untreated syphilis, do you not think that they were going home with that? Or in their communities? And so it impacted a community of individuals for the sake of research, but again, in our community. And then even, I think this is recent, but 1951, where Johns Hopkins, which is considered a very prestigious institution in Baltimore, they took the cancer cells from Henrietta Lacks, and there's a movie that's been done on it. I can't think of the name of it. But they literally were able to advance so much science from her cells that they stole from her, basically. But I think her family has just now been compensated recently for that. Okay, we can go to the next. Lack of diversity in the clinical trials. I won't beat on this again, but again, the benefit is that we get to learn some things about the demographics or how medicine affects us. So there are certain medications that don't work as well in black or people of color, that they didn't know that when they got it to market, because we weren't in the clinical trials. But once it's called post-market, right? Once it's on the market and available at the pharmacies, now you have millions of people that are on it. And doctors started reporting, when I put my my black patients on this, is a calcium channel blocker, actually, they're not responding. Their blood pressure is not being controlled, and we're not really sure why this is happening. So after a while, they got a lot of these reports, and then they did a study, and they found out that we don't respond as well to calcium channel blockers for reduction in blood pressure. So it's things like that that we need to know, because then how many times do you think doctors were telling them, well, you're not taking your medicine? No, I am. And then in the notes, non-compliant. They quote it differently now because you guys now have access to their notes, which is a blessing. Thank you, Obama. That was part of the Obama care when he was doing all of that. But then also, we benefit from it because we get to learn more about ourselves and our health, because clinical trials But let me caution you. I'm saying that, but I do want you to know that you need to trust the physician that you're working with that either refers you to a clinical trial or that's working in a clinical trial. You have to have that level of trust and comfort, because if you feel uneasy at any moment, because clinical trials take a minimum of like a year, if you're uneasy at any moment, you probably won't continue. So it really does work to our favor sometimes, but you need to make sure you have that alliance with your provider. Okay, we can go to the next. Systemic racism is everywhere, and it does not go away being in the health system. It actually doesn't. It's actually probably more prevalent, I'd say, in the health system, unfortunately. Systemic racism remains a fundamental cause of persistent health disparities in the U.S. More Black, Hispanic, Latino, and American Indian, or I should say indigenous people, are more likely to have lower high school graduation rates, individuals and household incomes below the federal poverty level because of systemic racism. And so there's this loop, right? So the systemic racism that I face in my daily environment now bleeds over into my health. And because of this, we have uneven access to quality schools, good paying jobs, better neighborhoods, health insurance, and also quality medical care. You can go to the next slide. And this is what it looks like. I'm not going to walk you completely through it, but you can see that this researcher was able to show and link it all the way back to when we were enslaved. And it just goes all the way through, like white supremacy, white privilege, right, which has been, I guess now is the buzzword. It goes through Jim Crow. It just walks you through how all of this has started from when we were brought here to these shores. Okay, next slide. Oh, I just always like to throw this up. So these are two colleagues. One was white, one was Black. They literally had the exact same job. They literally sit next to each other in cubicles. And so what this investigator did, followed them for 10 years. At baseline, the white woman who lives in a higher income area. Now, again, I told you they have the exact same jobs, right? Lives in a higher income area. She started out with a BMI of 28, borderline high blood pressure, and she reported being moderately active. But you'll see over 10 years, her weight was under control. She was taking her blood pressure medications, and she still remained moderately active. Now we go to her colleague, same baseline demographics. 10 years later, why is she in the wrong direction? Why is she heavier than where she started? She has uncontrolled blood pressure, and now she has prediabetes. The next slide hopefully will kind of make this clear for you. It's because of these, the social determinants of health. Economic stability. Well, we need employment, income, expenses, bills. I mean, all of this contributes to how we live our lives. And so I mentioned they had the same job. But do we know they had the same pay? Right? Probably did not have the same pay. And I know I'm in corporate America. I'm sure it's others here who work in a corporate environment, and they discourage you sharing what your salary is because they know they don't pay equitably. Neighborhood and physical environment, housing, transportation, how do they get back and forth to work? Parks, playgrounds. I talked about, being able to walk in your neighborhood. Sometimes that's not always the case. You might not even have sidewalks in your neighborhood, or bike paths and all of these other things that you see outside of the urban environment. And I mentioned one lived in a high-income neighborhood, the other one in a low-income neighborhood. Yet again, something else that is affecting their health. Education, that's important, but not just necessarily the education of the person, the education to be able to understand medical ease, right? So I can have a lawyer talking to me and it's like, oh, how much I owe you? I mean, it's like, I don't always understand that, and I hate how they write their stuff. It's like, what the heck, why do you whereas and as foreseen? Like, can you just make it plain? So it's literacy also. It's not always just what educational status you've achieved. It's your ability to understand what's being told to you. And so if a clinician comes in the room and they're talking all this information and you're looking at them like, okay, you walk out of that office not really knowing what to do. So education is important, whether it's literacy. Food is also a social determinant of health. Hunger, access to healthy foods also. What you'll often see, and I do remember this growing up on the south side of Chicago, it's like we had corner stores. Here we go. So you know about the corner stores. You go to the corner store, you get your, you walk in, it's usually some type of bulletproof glass up, you walk in, you got your potato chips, all your candy, you got your soda, you got your lottery tickets, you got your cigarettes, you got all the little stuff that you need, like maybe, we ain't going to the, we're not going to the store, but maybe you needed some grits. You know how you can get the little grits? They usually have like a little small box of Quaker grits in there. And I mean, it's just the necessaries, right? Probably don't have access to healthy foods when you go to the corner store, but it's what's convenient. And my grandmother, she had a vehicle, but she only used that vehicle for necessary reasons. If it was within 2 miles, we were walking it. So the grocery store, and I look at it now, that's what I love about Chicago. They had a lot of Black representation in the neighborhoods. And so we had Harvey Collins, he owned half the daggone block, but he had a laundromat, a grocery store. So we would walk to the grocery store with the little buggy thing, and we'd all come back. We'd have bags on our sides because we didn't have plastic bags back then, and my grandmother would be pulling that, but that's how we had to go to the market or the grocery store. And so if it was just something little you needed to pick up, you wasn't doing all of that. You was like, let me go to the corner store. But the corner stores were good because I used to get my they weren't called Flamin' Hot. It was the hot Fritos, yep. Dill pickles, yeah. Oh my goodness, I've never had that. But they did have that there. They had feet. Now they had it all there. So then also our community. How do we engage? I want you to be honest. I don't know where you live, so you don't have to say anything, but how many of you know more than 3 or talk to more than 3 households on your block? That's good. People don't talk to each other anymore. They're like, you wave, you're friendly, right? Hey, how are you? And then you pull on in your garage, and sometimes, depending on who it is, sometimes don't get out the car till the garage door is down because you don't want them sneaking around talking about, hey, how you doing? Like, oh, hey, how are you? So our community, we don't commune anymore. And now post-COVID, we commune even less. And if you don't think that has affected your health, look at the television. People are losing their minds right now because we are social beings, and we just participated in a very extreme experiment. What happens when you are isolated in your home? There's a lot of different, when you look at it, like the stuff that's coming out now, there's, they call it, if you remember when they talk about college, they say, oh, you're going to get the college freshman 15. Well, we are, I think it was 23 point something, so about 25 pounds on average is what people gain during this pandemic. So there's a lot of things that, that takes a point. And then if you live in a neighborhood that doesn't, that's not welcoming, then, you know, that's isolation too, you, especially depending on what you do. Now that a lot of people are working from home, they're really not interacting with people. And that is really making a difference. And people do want to get back into society, but they're cautious because you turn on the TV, and every time you turn on the TV, there's, it's spiking again. Oh, okay. And it is spiking. But the beautiful thing is people aren't dying from it because now they know how to manage it. Well, not as many people. There are still people who are dying from it, but not as many people are dying from it. And then our healthcare system, of course, that's a huge, 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 huge. Talk about resources to ask your providers when you go to the office next. But overall, all of that contributes to our mortality is our illness, right? So you live with illness, chronic illness. Morbidity is death, contributes to our death, our life expectancy, our health status, and our functional limitations. Because think about what you need to be able to do at a bare minimum to live independently. I tell people, you know, one of the best exercises you could do is squats. Anybody know why squats are so important? What do you need to do to stay independent? You need to be able to get up and down from the toilet. You need to get in and out of a chair and in and out of your bed. And if you're not doing a lot of this, if you haven't made these muscles strong, then you are unable to do that. I mean, like, you can assist yourself, of course, but you need to have these muscles strong. Okay, we can go to the next slide. Thank you, Kevin. So we talk about health insurance. This is the Obamacare, right? This is expanded Medicaid. This is why you need to vote. This is why you need to vote. I don't care if your president doesn't get into the White House. We've seen over and over again, they don't have as much power as we thought. Vote locally. That's who's making the decisions for you. Locally. Vote locally. And since you're already there, go ahead and pick a few federal folks. But vote locally. And it's important because you'll see here, during the Medicaid expansion, Arizona got into the Medicaid expansion because they saw that it would take some of the burden off of them. Arizona actually has one of the largest patient lives, is what they call it, on Medicaid in the nation. And so when they saw that they could kind of share the expense, that's one of the reasons why. I don't think that somebody was in your corner. It was financial. But then you see all of these other states that haven't adopted expanded Medicaid, and where are they? In the South, where we normally live or was from or something of that nature. And so that they call that part here on the green on the bottom right, they call that, they call a lot of things. They call it the diabetes belt, the obesity belt, the Bible belt. I mean, it has a lot of names to it, but that's a lot of people don't have access to health care. Next slide. I can skip the discussion questions. We've been kind of going through it. Thank you. So we talked about this already. You can skip this one too, Kevin. Thank you. Okay. This is also very important. So African American women, I really believe we're probably the most marginalized group in the U.S. You have disparities against you or discrimination against you because you're a woman, and then also because you are a Black woman. And if you look at some of the chronic illnesses and you divide it out by gender also, the Black female typically has a lot of the lion's share of those illnesses, with the exception of high blood pressure. That's actually our Black men that shine in that role. But we have to figure out how to advocate for ourselves so that we get healthier, because this is what's going to help us live our lives longer independently. African American women are 22% more likely to die from heart disease than a white woman, 22% more. 71% more likely to die from cervical cancer, and 243 times more likely to die from pregnancy or childbirth-related causes. And that is independent, the child care at least, the birth outcomes are independent of social economic status. That by far shares and shows or highlights that it is not simply just because we don't have access to health care. Also, non-Hispanic African Americans have 2.3 times infant mortality rate as non-Hispanic whites. I was looking at this the other day because I'm a data junkie, so I was getting ready to have a heated discussion about the Roe v. Wade overturn decision by the Supreme Court. And so I was looking just to see, I knew we had issues in regards to infant mortality, but I wanted to see what life expectancy was doing and what our population growth was doing. And I'll tell you that just about every other ethnicity has increased slightly in the percentage, well, I should say, outside of white, non-Hispanic whites, but they have gone up dramatically. Blacks, we're flatlining. We're not growing in population. And we can spend some time talking about why that possibly is, but a lot of it has to do with this. So 200%, almost 300%. So you figure if there are 5 babies born to a black woman, maybe 200, so like maybe 3 of them are living past 1 year, because that's how they determine infant mortality. Doesn't always have to be a stillbirth. They take it out to the first year. And that also has to do with coverage. So there's coverage for you to go for your well baby visits, that and also once you deliver. But then for some reason, all of that coverage goes away. And it's like, well, yeah, now I have to, get my baby seen. Well, they came for the checkup, they're good. So maybe now you have another child, you have other expenses, and maybe you can't afford the insurance that you need to have you, your family, and another child. And so, yeah, there's ways that you can get insurance for your child, but it takes time, right? And do know that if you can get insurance coverage, that you can still take that baby to be seen. No one can deny you care. But the caveat is this: why do we not worry with that? Because we talked about the quality of care. Usually those community health centers are not in the nicest neighborhoods or well manicured. I'm trying to be really politically correct. And it doesn't look healthy. Like when I walk in, I'm like, I don't feel like this is a model of health. And so we kind of stay away from it. But yeah, this is what's happening to our population right this moment. And nobody's done anything about it. Big question mark. Next slide. This is just another example of some of the things that shows disparities between women of color, more so African American women. And this is specific to people who have chronic obesity We can go to the next slide. So what's the aim? How do we become healthier people and get better care and spend our money smarter? You want to have your doctor partner with you. You are asking, like you wouldn't have someone come in your home that's an electrician and not ask questions if you didn't understand what they were doing. But we do that with our healthcare providers, and we should stop. If there's a word that you don't understand, you say, wait, before you go further, what does that mean? And have them tell you. I always tell individuals who have diabetes, when you walk into the room to be seen, take your shoes off. Your doctor should be examining your feet every visit. But they don't, because they're in and out. Have your shoes off, get ready to go. Oh, doctor, you need to look at my feet. That's something they have to check off. They sometimes will check it off saying they did it, but they don't. But know what you need for your health. So there's things like, and if you are unsure, let me know. There's guidelines for just about every chronic disease state that you can look up to see what you should be getting on a quarterly basis, yearly basis, every 5 years. They walk you through, well, not really you, they walk the physicians through what they should be doing, and you hold them accountable. We get improved care by making sure that we are making the decisions, not them. It's our health. They're our guides to help us navigate the craziness of the healthcare system, but ultimately we are the consumer. Next slide. So this is some things I put together. So consider your relationships with your provider. Does the provider office provide interpretive services? This is important if English is not your first language. And so there's a lot of Latinx individuals who really have an issue understanding. So that's that literacy part, because they're not understanding the words first and foremost, and then sometimes the language. So does your clinician provide interpreter services? Do they have minorities on staff? Do they work with traditional healers or community health workers? Do they incorporate specific cultural tools or resources for you? What about, do they include your family members or even your community in discussing how to improve your health? And then have they ever said, oh, you know what? I can't provide this service, but here's a place you can go. If you have a clinic or a provider that does these things for you, then you're in the right place. If you don't, find one. And it's okay to ask them this. You could ask them things like that. Hey, blah, blah, blah. You might not need an interpreter. But guess what? If you realize that your healthcare provider has interpreter services, doesn't that make you feel like he's involved, that he cares? Even if you don't need that service, the same thing. I mean, when you walk into, we speak a different language. I'm so sorry. I'm not going to call it Ebonics because I don't prescribe to that. I don't really know where that came up. But we speak a different language. And I don't know about you, but I can walk into an office, and if I see a sister sitting at them, I'm like, hey, how you doing, sis? We chit-chatting. I feel better already. Versus if I come into an office and no one looks like me in there. And it's like, hi. And, everybody's like, how can I help you? And then I'm like, she had an attitude. She may not have had an attitude, but I just took it that way. Like, she had an attitude. I don't want to come here anymore. So it makes a difference. Next slide. Oh, you can skip. You can go to the next slide, Kevin. Thank you. Oh. So we talk about medications. And I talk about medications a lot, well, because I'm a pharmacist, but I talk about medications because it's important to be able to, this is an easy pull. Like, you can get research on this without any issues because all of these pharmacies log everything you do and how often you get prescriptions filled, and whether you picked it up on time. They pass out all this information that they sell to individuals to look at. Just FYI, it's not your information, not like your date of birth or anything, but they de-identify the information, but you can find out information about how often people adhere to medication. And you think about this. So you have 2018, the median weekly full-time pay for whites was $916, blacks $694, Hispanics $680. This is according to the U.S. Bureau of Labor Statistics. So remember, we talked about those two colleagues. One was white, one was black. They had the same job. I can almost guarantee you they didn't have the same pay. One was able to live in a nicer neighborhood, but that's not always the case too. We get redlined, right? We get pushed into certain neighborhoods when we're looking. And then when you think about uninsured Americans, we outshine our Caucasian counterparts, and we're less than our Hispanic counterparts. But if you think about it, we get paid the less, and we have the less insurance. So again, here's that disparity. All of these disparities exist. Next slide. This is just an example of how you should approach being seen. So this was an approach, an integrated approach. So you need to see more than one person is basically what is coming up at. So 60% greater risk of all-cause mortality in patients with individuals with excess weight. And it's really based on the other comorbidities. So you have greater than 66% of individuals with high BMIs die from a cardiovascular event. That would be a heart attack or a stroke. You also have 30 to 50% of people, individuals diagnosed with type 2 diabetes every year due to excess weight. 13%, there's 13 types of cancers that have been directly linked to excess weight, breast cancer being one. 34% increase in the risk of dementia due to excess weight. And dementia, I know it runs in my family. So kidney disease and dementia, I get the fun stuff. Runs in my family. So you have to consider it's not just one thing. And so if you think you have issues with cardiovascular disease, are you seeing cardiologists every year? There's preventive cardiologists. That's what they do. Their goal is to either prevent you from having your first MI or heart attack or stroke, or preventing you from having your second, either or. Are you seeing someone about your prediabetes? Are you doing something for your prediabetes? Because once you get to diabetes, it's late. So if you have several risk factors, or you have another, chronic disease, yes, you need to see more than just one, because it's their training. So a primary care physician is usually, like you said, a family physician or general practitioner, or they might even be an internist. However, they have to learn a lot of systems. So the way that clinicians get trained is based off of the system, your body system. So a primary care physician is trained on all the systems. So as you can envision, he doesn't know every little thing about women's health, or everything about the heart or the brain. I mean, they can't know everything. No one can. Well, there's one person that can, but no one down here. So yes, I highly recommend that you see a specialist. at least once a year. So if you have issues with heart, you need to see a specialist. If you're a man and you have issues with high blood pressure, you should see a urologist once a year. Women should see a gynecologist once a year. So cholesterol is also, so let's say you have high cholesterol, and every time you go back to the physician, it's not getting under control. Then there's something that needs to be done. So there are cholesterol specialists. They're called lipidologists, like lipid, Lipid, which actually means like a fat droplet, which is what cholesterol is. You should tell your physician, if you're an HMO, you say, will you write me a referral because I want to speak with a lipidologist? And if he tells you no, he better give you a pretty good reason, right? And then you tell him, if he says no, you say, okay, can you make sure you put that in my notes that on today's date, I requested a referral for a lipidologist and you said no because of this. I need to make sure that's in my health chart. He's probably going to refer you to a lipidologist. You can go. PPO. Yes, but that's important because if you keep having the issue and all they keep doing is adding on medication, that's not going to solve it. There's other things that are going on, and maybe the medication you're taking, but I'm just saying, I'm just using you as a you. The medication you're taking is not working for you. So why not go to a specialist? Yes, ma'am.
What about people that don't have like HMOs and all of that are on public assistance? They get a lot less care than people that are actually able to pay for the actual health care.
I will tell you this, which I did not know. There are a lot of things, services that you could have access to if you're on, what is it called here, Access? If you're on Access, the reason I do know this is because I am the state health chair for the NAACP here. And I'm on the phone with them, and I'm like, wait, what kind of services do you have for dental care? Or what kind of services do you have for mental health? I mean, we were walking through all of this. It took 3 levels to get up to have someone talk with us. And surprisingly, there's access to all of this stuff, but no one knows about it. No one knows about it. And the doctors have to know about it to tell you about it, right? I was floored. I was like, well, why doesn't anybody know about this? So we're committing them to doing like a road show. So we're trying to get them to come out to doctor-related events so that they can tell them what's available, and then also come out to community events so they can tell them what's available to them, and you can advocate for yourself. So if there's something that you feel that you need to get, or anyone that you know needs to get, then dive down, dwindle down, and if you don't know how, you can always reach out to me. You're looking for me. Okay, just come looking for me. But yeah, because we have to learn, and then once you know, knowledge is power. Because in our communities, we usually talk. Yeah, like, girl, did you know? Da, 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 da. I was like, didn't realize that. And I will tell you, if anyone is trying to make a decision whether to be on Access or the managed care part of Access, stay on Access. You get more services on Access. Once you get switched over to the managed care Access, then now you have to play under their rules, the formularies, who you can see, what you can do. But Access has to be equitable. That's the whole thing behind Access. And they have to, in order for them to get their federal funds, there's just a whole lot of different things. So I always tell people, if you have a choice, don't go to the managed access. Stay on access. Okay, next slide. Yep. I think we can skip through that. There was just one more. You can skip through that. We talked about the affordable care. This is it. Lastly, but not least, you are a whole person. You need to have your whole being fed spiritually, physically, emotionally. But in addition to that, when you go to, when you have issues with health, who are you interacting with? Are you talking with your pharmacist, or are you just walking there to pick it up or going through the drive-through? And they're saying, would you like to speak with the pharmacist? You're like, no, I'm good. Ask questions. They go to school for that. Community organizations. Are you connecting with a community organization that may be, like if you have diabetes, are you talking with or volunteering for the American Diabetes Association? Employers and businesses. Know what your rights are at your offices where you work. There's certain rules they have to apply, and you have to get breaks. Know what your employer's rule of the road, I guess. I don't know what it would be called. Employee rights, employee bill of rights, I think it's called. Schools. If you have children that have illnesses or things like type 1 diabetes or learning disabilities, find out what your rights are there too. Make an appointment with the principal and say, hey, what are my rights? What does my child have access to? Administrators, nutritionists. If you have diabetes, you get paid, I think once every 3 years. I don't know why it's 3 years, but you get paid to see a nutritionist. Behavior health specialist, very important. And you're probably already seeing your physicians and nurses. But this is your healthcare team. And if you're not tapping into all of these individuals, whether they're in the health system or not, they still affect your health, because we spend a lot of our time at work. So my goal was to inform you give you a history of where we were, where we're coming, and how to improve your health and be more of an advocate for yourself. And I'll say this before we end. Vote. August 2nd is the primary. If you're not registered, don't worry about it. We'll get you registered before the November election. I need to mail mine in too. Yeah. Oh, I thought you had a question. Okay. Okay, let me look into that. Okay, so okay. Okay. There's actually a new medication that just came out that's supposed to have fewer side, but we'll talk about that. Can you end us in prayer?
Just before I pray, when next? This was really. Yes, I think it will be because there is a spike. It's beginning to surface, so we need to. I just want to say the information that shared was really, really informative. And so could we give it up for the doctor, right? And